Allison and I are going to be talking about the MU Rural Track Pipeline Program, preparing students for rural practice. And I believe, I should check, yeah, there's another slide that has the pipeline. So today we're going to talk about, and probably most of you are aware of Missouri health disparities, but I'm going to review them just to remind you. We're going to talk about the physician shortage challenge, the rural track pipeline overview, what's in it for the community regarding the program, steps to recruitment engagement, statewide solutions, ideas and discussion. We really want to know your ideas, how you want to be involved, how we can help you. And then we will take questions. Next slide. So this data is a few years old, but I don't believe that Missouri Hospital Association has updated this data, but we fell from 30th to 40th in the national rankings for health over the last several years. We ranked 42nd in senior health and 35th for women and children health. We have almost 6 million residents, and 38% of the Missourians live in rural counties. The majority of our rural counties are primary care health shortages. 69 of 143 Missouri hospitals are in rural counties, and 4 have closed since 2010. 32 counties are without a hospital, and many of them are rural access hospitals. And I was surprised earlier, I don't know, I mean, most of you probably were in Brock's presentation, and Missouri, as usual, we had more risk of hospital closures. We had high COVID. But if you didn't see Brock's presentation at 12:30, he had a lot of detail about health disparities, and I encourage you to go back and watch that. Next slide. So one of the issues is that our primary care providers, the average age is 60 compared to urban primary care physicians who are 54. That's still nearing retirement for both, but 60 is getting dangerous for rural communities. 61% of rural primary care providers are over the age of 50 versus 52.7% in urban primary care physicians. 19% of rural population is over 65, while only 14.7% are over 65. So we're older, poorer, we have less access to primary care physicians in rural communities, which I'm sure most of you know. Next slide. So this slide just shows the rankings for rural versus urban Missouri. And as I said earlier, we have in rural communities, there's poor health behavior, less physicians, and what we already went over with the age of the physicians being higher in rural communities. Next slide. So 90% of our counties are facing physician shortages. 37% of Missourians live in rural communities, and only 18% of physicians practice in these communities. Next slide. I'm going to turn it over to Allison to talk about the Rural Track Pipeline Program that we started about 25 years ago. That I was 2000. It was slightly before you were born, but it really wasn't. Go ahead, Allison, take over.
All right, thank you. So as I mentioned during my intro, one of my main duties and functions as part of the Rural Track team here at the University of Missouri School of Medicine is to maintain coordination of our BRYANT Scholars Pre-Admissions program. So as Dr. Quinn mentioned, our program and our MU Rural Track Pipeline program began in 1995 to address rural health maldistribution of physicians in our rural areas and our workforce shortages throughout the state. So we're actually going into, I think, our 26th year. So last year was 25 years. We're just going to forget all of 2020 with COVID. We're just going to act like we're redoing the whole year over. But as you can see, Lester Bryant was the dean of our medical school from 1989 through 1998. He was one of the main promoters of our program and really helped to get it off the ground. He was from rural Tennessee, and he was a cardiothoracic surgeon, but also realized that actually getting physicians out into rural areas was a big need, especially from where he was sitting as someone from a rural area, and wanted School of Medicine to get into the fight and start producing more physicians for our rural areas. So our program, we have different components. So we have our Lester R. Bryant pre-admissions program, which is one of only 2 pre-admissions programs currently at NU School of Medicine. We do have a set curriculum for our undergrad students. And as soon as those students do matriculate into medical school, we do have the Rural Scholars Program, which we will go into more detail about as well, which includes 3 clinical components that are the Summer Community Program, Rural Track Clerkship Program, and Rural Track Elective Program. So program design, our program design was based off of 3 premises from literature. So students from rural areas are more likely to return to those rural areas, and obviously Missouri students are more likely to stay or return to Missouri after their residency is completed. We've also found that longitudinal experiences that include living and working in rural communities also increase the likelihood of an eventual student going out into eventual rural practice. So that is the main goals of our program, is we want to train our students, give them opportunities to have longitudinal experiences throughout all of medical school, and then hopefully that will influence them to go back into rural medicine, whether that be in a specialty like surgery or into primary care, and working with our rural communities. Each year, we have 20 dedicated rural pre-admission spots within our School of Medicine. So we do have 128, class of 128 per year for our medical school. And so these students are offered acceptance into a particular class in medical school. We do have them maintain certain academic standards, which I'll go into, demonstrate ongoing professional conduct, participate in all of the required activities that we have listed for them. And then once they do matriculate, they are required to participate in our Rural Scholars Program in medical school. So in order for someone to be eligible to apply for pre-admissions to the Bryant Scholars Program, they have to have an undergraduate graduation date 2 years from the time of application. So we will be opening a new application season in January, February of 2022, and those students who apply for that will be planning to graduate in May of 2024. We also require our students show high academic achievement during high school and undergrad. So we do have a minimum GPA requirement of a 3.3 for both cumulative and math science GPA as well. They have to receive A's and B's in the required lecture and lab courses. We require the same courses that general admissions for the School of Medicine has. Show evidence of leadership and extracurricular activities. They also have to be a Missouri resident and also have a rural permanent home address that is a RUCA code of a 2 through 10. And so we do want to, this is a recent change that we made within the last year and a half, 2 years, to include more students who are in sort of conglomerate areas outside of Jefferson City, we used to use the NCES database. And so we did lose some of our students through those codes because some of the places outside of Jefferson City were considered not rural, which most of us know are considered pretty rural for our program. They also have to maintain full-time enrollment in a public or independent 4-year university. We also do allow students who are completing their community college education, if they let us know where they have been accepted and where they're transferring, they can also apply for our program. So as I mentioned, our School of Medicine total number for our class size is 128. We do have we call it our pre-professional scholars committee, which is in essence a smaller version of our admissions committee that is made up of faculty and staff and some of our community-based faculty from our rural areas. We just had our interviews last week. And so our students are asked questions that range from things about Will they excel as a patient-centered physician? Two rural questions about whether or not they see themselves living and working in a rural area and going back and practicing in one of those rural areas. Our applications open in January, February of each year, and then the separate pieces of our application are due in June and July each year, and then we do interview in August. So once our students go through the whole process of completing the application, sending in supplemental materials, and then interviewing for our program, they are required to maintain that 3.3 GPA that is cumulative, and also we do pull out their math and science, and they must maintain that 3.3 math science as well, maintain those A or B grades, be professional, comply with all of our student conduct requirements. They're also required to take the MCAT exam. And so right now, our minimum requirement for them is to reach a 503 with their scores. So this current class will be graduating in May of 2023. We do not allow any early or late matriculation. Once they are admitted into our program, they will matriculate with the cohort that they have been assigned. They're also required to attend winter webinars that we have each year, and then also full summer retreats. Our summer retreats are 1 week long, and they are mandatory for our students. We go into a full in-depth curriculum review during that time. We also require them to log 20 hours of physician shadowing per year with a rural physician mentor, and write 2 reflection papers based off of those experiences. Log 20 hours of other health-related activities per academic year. That can be with other physicians, other allied health professionals. It can be with physical therapists, working in hospice, volunteering in nursing homes, things such as that. And then logging 8 hours of community service per year. And so this is just a quick overview of our summer retreat curriculum. We really try to jam pack as much as possible with all of the curriculum overview for the first 2 years of medical school to try to take away some of the anxiety that our students have about starting medical school and help them to become more confident as they go in. We always go through and work with them on filling out how they're going to fill out their AMCAS application, which does include writing a personal statement, which many of them don't have a lot of experience with. It's important for us that we also expose our students to our PBL curriculum. So our students do go through 2 full PBL cases during the 2 years prior to their undergrad graduation and matriculation into medical school. We also have been very lucky to work very closely with our simulation center here on campus to have our students actually work with standardized patients and go through some of the processes that they'll have to go through as first-year medical students. And these are just a couple of fun photos of different retreats. Unfortunately, the last 2 years, due to COVID, we haven't been able to have our students on campus. So we haven't been able to do as many face-to-face team building activities. And so we're hoping in 2022, we'll actually be able to have our students back on campus for at least a hybrid schedule where they're on campus for a couple of days, and then we do the rest of our retreat virtually. This next slide here, we do collect our USMLE exam data and also end of block exam data for our students. And as you'll see from these charts, there is no statistical difference between our students and regular NU School of Medicine student performance on step 1 and step 2 or their end of block clerkship exams during their 3rd year of medical school. Our students don't do any worse, and in most times they do better than their peers that stay on campus for programs. And then finally, we do have some outcome data for our BRYANT scholars. So as you'll see, we do have about 45.6% of our students are physicians in primary care. 52.4% of those graduating students entered a residency program in Missouri, and 38.1% entered a residency program at Mizzou. And then current practice locations, we do actually have 67.3% of our students do practice in Missouri, with about 59.4% of those students practicing in rural areas. So we like to see that our students are going through our programs, they're going back to rural areas, and it is a wonderful experience. For me, I've been here around 7 years to actually see students go through residency and then decide to start precepting our new students. So it is a wonderful pipeline to see in action. there any questions about the Bryant Scholars Pre-Admissions Program? Okay. Well, I will turn things back over to Dr. Quinn to talk a little bit about our Rural Scholars Program. You're muted, Kathleen.
Okay, thank you, Allison. Next slide, please. So the Rural Scholars Program is designed to offer the students that are interested in rural practice the experiences while they're in medical school. And Allison mentioned that we pre-admit the 20 students, but we offer for students that didn't know about the Bryant Scholars Program, or there's sometimes urban background students that don't want to live in an urban area when they enter practice, and they decide that they want to try out rural medicine. And so we leave about 5 slots open for students that can apply as M1s. We just want to make sure that, again, that everyone has the opportunity to participate. And they apply in the fall. So how many Bryants matriculated this year, Allison?
18.
18. And so you might be asking, why isn't there 20? Well, some years we don't get 20, or sometimes when we pre-admit after their sophomore year in college, they change their mind and decide they want to do something else. So we matriculated 20 so we can actually take up to 7 of our M1s into the Rural Scholar Program that were not pre-admitted. So we're always excited to be able to offer the opportunity to other students. We want to offer those slots to students that are interested in underserved populations or learning more about rural health disparities and quality of life concerns in Missouri. So it's the ability to target more of the right students and commit resources to strategically impact the educational experiences and that allow to produce more physicians for rural Missouri. We have found, and this is in the literature, if they're from rural Missouri and they train in rural Missouri, they're much more likely to practice in rural Missouri. Next slide, Allison. So the benefits. We want the students to develop ongoing relationships with the leaders at the hospitals in rural Missouri. So I know there's some people from hospitals on. So we have many smaller hospitals that participate in our program, and then we have 9 larger hospitals where students can do all of their required clerkships, for example, during their 3rd year. And I think we talk about the continuity clinics later, but they go back to the same part of the state over and over. So the leadership at these hospitals really get to know these students, and the students really understand the rewards and challenges of working and living in a rural community. They also get to start their clinical experiences after the 1st year of med school, usually at one of the smaller hospitals. They all have a personal mentor from a rural community, a rural physician that helps them for any kind of questions they might have. And then we take pride in the personalized assistance that we give these students. And another thing that the literature tells us about retention in rural communities is that physicians who are prepared for rural practice are more likely to stay. And what I mean by that is when you're in a rural community, you just have a broader based practice. There may not be, a specialized surgeon, or there may not be an OB. And so if you're a family physician, you might have a broader based practice, or a pediatrician, than you would in a more urban setting. Next slide. So whether or not you're a pre-admitted Bryant Scholar or a rural scholar, all the students are required to complete between their 1st and 2nd year a 6-week summer community program, or 4 weeks of the summer community program, and the 2-week clinical rural immersion program. So the summer community program, the students work, as I mentioned, usually in smaller hospitals, and they work one-on-one with usually primary care providers day in and day out to learn what practice is like. And these physicians and their sponsoring hospitals take the time to really work with these students to help them understand what it's like to be a physician in a rural community. The clinical rural immersion program we started 2 years ago, and they've both been pretty virtual, unfortunately, but that is a program that is in cooperation with the School of Nursing, School of Pharmacy, and School of Medicine, and it's grant funded right now. And students go into the community. The first year it was sort of virtually in Sedalia, and then we tried to do it a little bit more in person in Sedalia this year, and next year it'll be in West Plains. But they do a lot of interprofessional care during that 2 weeks, but they also do some specialty care. We also help them understand the community at large. What is their role beyond being a physician in a rural community, and how will they see themselves fitting in? So it's been a really great program that we look forward to continuing when the grant dollars end. During the third year, students are required to do at least 3 of their clerkships and a community integration project. So what I mean by clerkships, during the third year of medical school, students do clerkships in internal medicine, child health, psychiatry, neurology, surgery, OB, and they do 2-month blocks. And so they have to do half of their clerkships in a rural community. The community integration projects we started about 15 years ago. And we found before that the students' existence in these rural communities might be a triangle between the hospital, their housing, and the grocery store. And medical students usually are service oriented. And so we started doing community integration projects with local organizations and agencies where the students could give back while they were in those communities. So they might do something about working with young children about sun safety or fire safety. We've had students that have taught barbers about what melanomas look like. And so if they have a customer that has a lesion, the barber would refer to a provider. We have organ transplant. I mean, there's just so many different projects that these students come up with to make a difference. And then they give a research poster at the end of their year. And so it gives the students an opportunity to learn how to do research and present to put on their CV for residency. And then finally, they complete at least one 4-week rural elective, again, back in their continuity region. And I will say that the hospitals that we work with, Extension helps with these community integration projects, and it's truly a academic community partnership for these students to be in these communities during their third year. They also attend 6 evening lectures that is funded by our grant through the Department of Health and Senior Services. And some of the topics that we've covered, telehealth and the primary care provider, managing a successful rural practice, exploring mental health, opioid treatment, FQ8Cs. So if any of you have a special expertise and you want to give a lecture, historically they were in person, but one of the silver linings of COVID was we are doing them. Not that doing things virtually is great, but we are able to now have 80 or 90 students, and we've opened it up so it's interprofessional. So we have nursing students, pharmacy, social work. We open it up to any student and faculty that's interested. So we generally have rather large audiences for these since they are virtual. So if anyone's interested in providing a lecture, that would be great. And then again, they have their mentor in their rural community. Next slide, please. So as I mentioned, the rural scholars are assigned to a continuity training site where they complete all of their programming. And again, the students will know their assigned community during their first year. And it really, I mean, Missouri is so diverse. If you compare Northwest Missouri to Southeast Missouri compared to Northeast Missouri, it's so different. And some students want to go to the region in which they grew up. Other students want to go to a completely different area. But the students really get to know, again, not just about the medical community, but what is the economic base of that region of the state? What's the population? What's the demographics? How can they become a better professional to help in that portion of the state with the issues that area is dealing with? Each year we have a training site there. It's in the fall. So last year it was virtual, and hopefully it won't be virtual, but all of the sites come to Mizzou. And the students get a passport and they go around and they talk to the physicians and or recruiters at all of the different sites, and they figure out what site that they're most interested in. So it gives them some education and some knowledge about which region they think that they would benefit from. Next slide. So this map shows where our larger sites are and the hospitals that partner with us. And again, Department of Health and Senior Services helps fund this program, as does the Missouri Hospital Association, and we get some federal dollars as well. So we have medical directors at each of these sites, and we also work with the AHECs and coordinators at the hospitals that help take care of the students. We don't just send them off. They are very self-motivated students because they are away from campus, and they do go through all of their learning more independently than the students do here. But this is all of the logos of the hospitals that we have our academic community partnerships with. And again, I'll say that we cannot do this program without these partner hospitals, and we're extremely grateful to them. Next slide. So the summer community program, again, is between the first and second year. And the students, it used to be that the rural hospitals paid the students a stipend. And as we know, rural hospitals don't have a lot of funding any longer. So the Hospital Association is helping to pay the student stipends for this program, and housing is free of charge. Some students stay with family or friends, but it's an opportunity for students that have only gone through 1 year of medical school to gain history taking and physical exam skills. But they do see between 600 and 750 patients during that experience. So it really gives them a solid base of what rural practice is going to be like. Next slide. Okay, so I've already talked about clinical rural immersion program, but this, it is between their first and second year. This is the 2-week interprofessional experience that I was talking about. And you can see some of the things that they get to do. That not only the clinical rotations, but we do have didactic discussions. They do all kinds of community events. They've done the poverty simulation. They do farm tours. I mean, everyone is involved. And so it's super cool. And they live and work in that community for 2 weeks. And again, they can kind of visualize what their life would be like later on in practice. Next slide. And then third year, we've talked a little bit about that. It's obviously during the third year of medical school, and this lists all of the rotations that they can do. They usually do 3. However, I'll briefly talk about the longitudinal integrated clerkship that we started this year. Longitudinal integrated clerkships are done all over the world. And instead of just going for 6 months and doing 3 of their rotations, they actually stay there the whole year, and they follow a panel of patients over the course of the year. So it's not done in blocks, but if you follow a patient, say, for example, if you're following a woman in a family medicine and she gets pregnant and goes to OB, and then the baby's born, and then the student would follow the child to pediatrics. And then, if there's any complications, the mom might have to go to internal medicine or another specialty. Or if she has to deal with any sort of postpartum depression. Psychiatry might be involved. If she wants to get some plastic surgery to repair her body, she might go and do some plastic surgery. So it's basically following that panel of patients throughout the year. So it's more real life medicine. So we're trying that out this year in Sedalia, and then we will expand that to 2 other sites over the course of our grant. But the goals of the medical education are met through the ambulatory setting. And it's integrating the learning across the disciplines, and the students benefit because they see patients across the continuum, and the patients also benefit because they have that continuity of care. So we're very anxious. The students just started June 14th, the 3 students that are doing that program, and we're super excited for the students, and again, extremely thankful for the physicians and other providers at Bothwell and Sedalia that are helping the students do this innovative program. Next slide, please. So the benefits are better or equivalent performance on the standardized exams, clinical assessments. So when you look at the literature, the students do, again, as well as students that have the block exams. It improves the patient-centeredness and empathy, again, because the patients are across time. And I think I've talked about the clinical training and the higher levels of preceptor satisfaction, because the preceptors don't have the student for, a month or 2 months all at once. So the students are also spread out, so there's less preceptor burnout. Next slide. So again, these are the 3 sites that we're going to be working with over the next 3 years. Bothwell started this year. We're working with Hannibal to start next year, and then Mosaic and St. Joe the following year. And then I talked a little bit about the community integration projects. And again, they are evaluating a community research project to address an identified need. They do the academic poster, and they get to submit their paper. And these are just some of the students that are presenting their research. There are judges. It's very serious. And even though the students are smiling, they're probably like super scared in this moment. But the faculty are very nice and give them productive feedback. And I think the students are so thankful to have that research experience. Next slide. And then the 4th year electives. And Becky Ernst is on the right, and she is a 2nd year medical student, but we put her in a 4th year picture as a goal. And then on the left is Fallon Mayab. She is an OB who actually was a Bryant Scholar a long time ago. And she and her husband, well, they were both Bryant Scholars. And Fallon is working in Sikeston, and her husband is working in East Prairie. She's an OB, and her husband is family medicine. So that is the success of the program. And I feel very confident that Becky will also end up in a rural community. Next slide. So the graduating cohorts, a class of 2023 has 12 scholars. And you can see down the line how many students that we have. And this year we had 18 Bryant Scholars, and applications for the other 7 slots are due in a month or 2. And next year we have 22 Bryants entering, and the applications for the other 3 will be due in November. And this year, I believe we interviewed 34 for the class of 20, and the 22 for the graduating class of 2026. I know we only have 20, but I will fight tooth and nail to get the other 2 matriculated if it comes to that. So I'll talk to the dean. And this is a picture of at the site fair. And then Riley Short is doing some simulation work in the bottom photo. Next slide. Next slide. So you guys can read the quotes, but Sophia Greer is a non-traditional student. And I believe she's from Atlanta and New York. And she very much wanted to experience rural medicine because she's interested in serving the underserved. And so she has done all of our rural programs. Is she a fourth year already, Allison? Still third? They grow up so fast, but this might have been when she was in the summer program, and now she's doing third year. But the physician on the right is Scott Kirkley, and he was also a Bryant Scholar a long time ago, and he's an internal medicine physician in Farmington, and Farmington is one of our sites. And Sophia is just having a fabulous time learning with hands-on experience and working one-on-one with her provider. So it's just, and then Magdaleno Gutierrez, this guy does everything. So he did summer community program. He's done rural immersion. He did clinical rural immersion. He did his summer program in West Plains. He's now part of the LINC in Sedalia. He's a third year medical student. He's from LA, but then his parents moved, I believe, to North Dakota. And he actually is now in Sedalia for the LINC. And we hope that he might stay. He's very much enjoying Sedalia, and we hope he might stay in Sedalia. But he also testified for us on a law that we're trying to get passed through the Workforce Coalition on a tax incentive for physicians who teach. So this young man can do it all. So we're very proud of him. And Elizabeth Blanton is from Sikeston. She's currently a third year in Sikeston. She was there for summer, and she talks about her OB experience again with Dr. Mayab. And she said she thought she wanted to be a pediatrician, but after working with Dr. Mayab, she might want to be an OB. And as you all know, we very much need more maternal health in rural communities. So whatever specialty she decides to go in, she will be meeting a need. And her father has been a preceptor for us in Sikeston since I've been around, so for probably 22 years. And he's a pediatrician. So I'm not sure how happy he is that Dr. Mayab is influencing her towards OB, but again, I'm sure he's happy if she returns to Sikeston for practice.
Her grandfather is also a pediatrician, so
she's breaking the mold.
Yeah.
So Madison, this is a rather long testimonial, but she talks about she's one of our LINC students along with Magdaleno, and just talks about her hands-on experience. They just love the programs. And again, the students, they leave campus, they are risk takers, they're innovative, and we're just so proud of all of them. And if any of you want to visit the students or talk with the students or go to one of the sites, definitely let us know. But when we offered up the LINC, Madison and Magdaleno were both super excited and jumped on board right away. And what's our third student? They all have the same initials.
Brittany Marshall.
Okay, so it's Brittany Marshall, Madison Bulger, and Magdaleno. Thanks, Allison. Next slide. So questions about, we can go back to full screen. Questions about the Bryant Scholar programs, questions about the Rural Scholar program, our outcomes, the program in general. Oh, I forgot about these slides. I'm super prepared. Any questions so far? So how can members of MRHA help us with recruitment engagement? So if you know of any high school or college students that would be interested in rural medicine, please let us know. You can refer the students to the AHEC in your region or to one of us at the School of Medicine, and we're in AHEC as well. If we try to inform the communities when there's going to be students in their community, whether it's through the summer program or Rural Scholars, because community members are super important in integrating the students into the community because they want to feel involved, and they have community integration, but they also like to go to the farmer's market or go to church or do a health fair that's going on or be part of 4-H. So if you want to know what students are in your community, let us know and we can send you that information. Give the students a community tour, involve them in your organizations, volunteer to be part of rural immersion or clinical rural immersion. And when we do place a position in your community, it's always nice to be welcomed by members of the community. Again, it definitely increases their retention. So collaborative projects. So we do work with the hospitals that are part of the Health Network of Missouri, and those are Hannibal, Lake Regional, Cap Region. And Cap Region isn't a rural site, but we do take the family medicine residents from Cap Region and we train them in maternal care at Mizzou, since Cap Region doesn't have that to offer. So that's part of our grant with the Department of Health and Senior Services. I've talked about the lecture series. We've talked about rural immersion. And then we got a federal grant that our department's not in charge of. Our graduate medical education family medicine department is starting a rural family medicine residency that will start next July with 2 family medicine residents in Sedalia. So we're very excited about that. And then the Hospital Association, they've helped us with the Rural Scholars Program, funding some of our sites, paying the student stipends for summer community program. So we're very thankful to DHSS and MHA. Next slide. So I mentioned the Missouri Healthcare Workforce Coalition. Some of you might be members, but we've brought together since 2016 key stakeholders who are committed to growing primary care. The goal is to increase the number of primary care providers practicing in Missouri. And that's not just physicians. I want to say it's also nursing and really any provider that wants to practice in a rural community. We want to help retain those providers in rural communities, increase the number and improve the distribution. As we know, there's not enough providers in any profession, but they're also in bigger cities, Columbia, Springfield, St. Louis, Kansas City. Promote a statewide infrastructure to measure and evaluate healthcare workforce trends. And at the previous presentation, I talked about the healthcare workforce data system, where we gather minimum data on all of our providers so we know where people are practicing and where the needs are to influence policymakers. And then we also want to develop a responsive policy proposals to engage coordinated advocacy efforts. And I mentioned the tax incentive for physicians that teach. If anyone's interested in more information about the coalition, please let me know. Our next meeting is in the morning on October 1st. And many of the schools, Department of Health, Primary Care Association, DHSS are all part of this coalition. Next slide. Okay, now we can talk about ID.